Well, good afternoon and welcome to the Elizabeth McGowan Training Institute at Morningside Ministries. We now call ourselves mmlearn.org because it's the easiest way to remember who we are and to be able to find us on the internet for training. I want to welcome each and every one of you and tell you that today in San Antonio, I hope when you're watching this, it's cooler where you are because it's a very warm, muggy day. So whatever day you're watching this, I hope the weather's better for you. Today we're going to be talking about ethics and aging. And some of the topics we're going to cover are research, driving, gambling, and sexuality. And you can only guess with so many topics. We won't be able to go really into depth doing that. But we're very excited you're with us, and I think it's a very important and very timely topic for us to be talking about. If you do have cell phones and pagers, I'm going to ask you to go ahead and turn those off. I know you're watching this from a distance, but the truth is sometimes you're in a room with other people and it can be disturbing. For those who are sitting here with me, there's no problem. If they need to take a call, they can step outside and do so. There's no disclosures to make it all today, so I'm going to just run through these and let you know that there is no conflict of interest in anything that we're presenting today. We're not doing any endorsement of products, and we have no off-label use in this program. The objectives you can read later and go back and look at our PowerPoints, and I wanted to make you all aware that this program has not been approved for continuing education for nurses, social workers, or nursing home administrators, but it's going to be changed up just a little bit. There'll be some things that are going to be added, and it will be made available within the next month for contact hours. So if you're interested in that, let us know, and if you'd like more information, it'll be online, but you can always contact us at info@mmlearn.org. Today I'm your presenter, and my name is Maria Wellish. I am a registered nurse, and I'm also a licensed nursing home administrator. And also, I think because of the topic we're going to talk about today, I'll also tell you that I'm a certified assisted living manager because many of the problems and issues that we have to deal with are as fundamental to assisted living as they are to long-term care, as they are to the community. And I serve at Morningside Ministries as their Vice President of Corporate Education, so we're just delighted that you're with me today. If you want to ask a question at any time during the program or to make a comment, I encourage you to click on the little bubble in the upper left-hand corner at the top of your screen, and you can ask a question. And we love knowing where we're being watched and how many are watching us. So just let us know that you're even out there, because it's a very small class with me today, and it makes it fun for us to know who's on board. So tell us a little bit about you. You don't have to use the bubble. If you're in a large class, you can write it on a piece of paper and give it to a facilitator. And you can phone in the question at area code 210-734-1222. And please know that if for some reason we get tied up with time and I can't get back with you with the questions, we're absolutely delighted to answer these, and we try to get back to you within 72 hours with an answer. You do that by just clicking on the bubble again. It sends us an email right to our address, and we'll return and get you the answer that you have. So we look forward to those questions, and we get a lot after most of these presentations. Before I begin, and before I even address the topic of ethics, I want to tell you that very seldom do we deal with ethical considerations alone. You have to think of yourselves as being a team. And when we think about that team, those of us in the medical environment always think about ourselves as being part of an interdisciplinary team. So we're thinking of ourselves as being nurses, doctors, social workers, clergy. But I want you to know that many times these decisions are guardians of family members or guardians that are out in the community that have been given this responsibility. They include the psychologist, they include the family doctor, and we can never leave out the family members as part in getting more and more information to make good decisions. So I think this picture is really good. It really encompasses and helps remind us we're not all alone when we're involved in these very difficult decision-making processes that are going to face us. Before we begin, I think it's imperative to know, especially if you are a licensed professional, that you must remember that you have a code of ethics that you work under. So if you are a physician, you're a nurse, you're a social worker, I don't have up here all the logos of all the organizations that guide us. But I want you to know that we must remember that we must be true to our own code of ethics for the profession that we're representing when we're on a ethics committee. I'm going to make a point here, and I think it's a very important one, about not forgetting, and I'm going to use nurses in this case, But the American Nurse Association has a code of ethics, and this is a guideline that is considered non-negotiable, and it supersedes the policies of an individual organization in regards to nursing practice and ethical decision-making. This is not different for social workers. This is not different for physicians. This is not different for clergy. Our code of ethics will always supersede what an organization decides as their policies and procedures. It doesn't mean that they can't be co-joined and we can't find a way that we work together. But I want you to know that you have to be true to your ethical and the code that guides your profession. Other professional disciplines, as it says, are guided and held by these, but I've put a link on this one for nurses because that's who usually joins us the most. And if you click on any of these links, you'll go immediately to this. And also on the top bar is a little, it looks like a paper clip. And if you click on that, again, you'll be able to go and find any of these links. We've put them up there for you. This was really interesting because when I went on to this link, I even found things on here on guiding nurse ethics in polypharmacy and other things. So take some time, and I think many of us get so involved in our professions, we sometimes forget to go back and review our code of ethics that guide us. So I'm going to start with a case study, and then we're going to move from there. So let me just read this to you, that Miss Landry is an 88-year-old woman, and she was recently admitted to an assisted living facility, and she has a mild cognitive impairment. She's very high functioning. She's recently lost her husband, and the family is really looking for her to have more interaction with other residents. They're looking forward to her participating with activities, and this is a woman who's been very lonely. Mr. Smith is also a resident in this facility. He's 92 years old, and he is a married resident. And his wife does not live in the facility with him. She lives out in the community. He's cognitively intact, and he's wheelchair bound. So this kind of gives us the background of the two people that we're going to be talking about. What's the issue? Well, the issue is that the nursing staff are beginning to note that Mrs. Landry and Mr. Smith are beginning to have more and more intimate touching, holding hands, even seen kissing each other on the cheek. Pretty innocent and as it looks, but there's some concerns, and the questions are around the staff are questioning the competency of Mrs. Landry to enter into any type of relationship, and the morality and the reaction that Mrs. Smith may have in regards to her husband's behavior and his own morality as he's proceeding. But remember, we're talking about somebody with mild cognitive impairment and someone else that we have determined is cognitively intact. So this is the case that we're going to look at in regards to sexuality. There are 4 basic ethical principles that are used to guide ethical decision-making, and those are autonomy, beneficence, non-maleficence, and justice. And I love this picture in here because it's a guidepost or a signage for us for ethics. At no point do I want to tell you that I think ethical decision-making, ethical principles are easy to follow. This is a difficult problem for anybody who has to deal with it. But I hope by the end of today's presentation we have a different view. And I'm always bored when I go to programs about this, and I hope today I'm surely not going to bore you with these. But it's very important that we understand what these definitions mean. So let's talk first of all about autonomy. It's often referred to as self-determination, or the right to govern oneself, to freely choose one's action as long as these choices, and remember this, as long as these choices do not interfere with the autonomy or the rights of another person. So it's that self-determination, self-governance. And you might wonder where I'm getting these definitions from, and on the screen you see that I have a book called The Essentials of Gerontological Nursing, and this was written by a woman by the name of Meredith Wallace. It has a 2008 copyright. I think this gives some of the best information on ethical decision making, and it gives lots and lots of different case scenarios. So I just refer this to you because you may want to use it. I also want to give credit where credit is due also. In beneficence, we're talking about doing good or participating in behavior that benefits the recipient of care. Now, I want to be very clear here that when we talk about ethics, There are so many people involved in the ethics, but we have to remember who it is we're caring for and who is this decision-making being made for. And in this case, when we talk about these two individuals, this is where we're going to be focusing our interest and our concern. So it is the recipient of the care, because it can change for other people that we're providing ethical decision-making for. That'll become clearer. The next thing is non-maleficence, which is about, above all, to do no harm. And this is something that I think guides all of us, no matter what, is remembering, above all, do no harm. And that seems pretty simple, but I want to tell you how involved this one gets. Finally, I think the most confusing when we deal with ethical decision-making is on justice. Because what justice means in this case is the fair allocation of resources to individuals or to the provision of equal share of available resources to each person. A lot of words, a lot of things around justice, but I think as we go through this one case study, I think you're going to be able to see why justice becomes so important and how applicable it is to all of our decision making. I used to not understand this. It makes a lot more sense to me after all these years. So we're going to use these 4 principles for the case study for number 1. So we're going to go back over these, and I'm just going to review them with you very quickly. And I hope that there's discussion when we finish and we get through this program today among those of you who are together watching it with other people or with your staff or fellow people who are sharing problems that you're dealing with in your facilities. But I want to start with autonomy in regards to this sexual relationship. In autonomy, let's go back to the right to govern yourself or to so freely choose your own action as long as they don't interfere with the autonomy or the rights of another person. So in this case, the right to autonomy is especially complicated. And the reason it's complicated is because of the presence of the mild cognitive impairment of Miss Landry. That's one of the first things. Is she capable of making decisions on her own? Or does her cognitive impairment in some way take away that autonomy? And it has to be explored. And as caregivers, it is our responsibility to make sure that her competency has been fully explored and that we have had physician, and we have to know that we have a lot of information about that level of cognitive impairment. Does her decision-making capacity or incapacity in any way, I think, interfere with her making good decisions about an intimate relationship? That's what we're talking about in regard to Ms. Landry's autonomy. Now, the other side is Mr. Smith. And Mr. Smith, in his case, he most certainly has the right to consider his, that we must consider his autonomy. Because this is a gentleman that we have determined and we are totally aware has no cognitive impairment. No reason to believe that he does at all. But even so, in regards to autonomy, what happens when we get down to the moral values of him making these decisions and the life experiences of the nurses and all those who are around him that want to project their own feelings, their own sense of morality on someone who may, in his marriage, have had an open marriage, whose wife may have always known that he had other women in his life, that this may have been acceptable to both of them? Are we in any way interfering with the autonomy of decision-making based on our own moral judgment rather than that of those family members and those people of whom we're treating? So we have to know that these are what are guiding us in autonomy. So the issue for Ms. Landry is she capable of making an autonomous decision, and one that we are sure that she has enough cognitive ability to make those decisions. Let's go ahead and talk about the next one, and that's doing good, or participating in behavior that benefits a recipient of care. Well, the actual and projected outcomes, I love this, of the intimate relationship would require an assessment to determine what nursing actions are required in regard to this relationship. Does this mean that people should still be able to be the recipient of care, and does that mean being able to actualize their sexuality? Yes, it does. And if both of these people can benefit, to the benefit of the recipients of the care, benefit from this relationship, is this something that we're offering and helping with? If we do the assessment and we find out that Ms. Landry is incapable of understanding the risks of this relationship, then do we have to intercede for her safety? Yes, we do. Are we responsible for protecting her? Yes, we are. Do we always know that we're doing the right thing in the protection? No, we don't. But we have a responsibility to know that because of her impairment, this may not be to her benefit. Many times, once the family gets involved, physicians and other people, even if there is a cognitive impairment, her benefit may be that she is so happy, so relaxed with this relationship that everybody is in agreement. This is appropriate for her. But it has to be for the benefit. If this was a woman crying out, being frightened, under no circumstance would it be appropriate for us to allow this relationship to continue. Those are the simplistic parts of these. Some of these become much more involved. Now, what about for the gentleman involved in this situation? If it's to his benefit but not to the benefit of her, it has to be to the benefit of both. One cannot be at the expense of the other, representing the benefit of care. So we have to make sure that Ms. Landry's not being taken advantage of, but we also have to make sure that the autonomy and the benefit to the gentleman, if it's all right, is being addressed as well. Above all, to do no harm. Well, in this case, I want to tell you that failure to assess Ms. Landry would be to do harm. There is no question. So when we look at our responsibility, above all, to do no harm, to turn our head or to pretend that we don't see something can cause harm. This can cause just incredible, I would say, to anxiety, and we've seen this in residents. You read about this, but more often those of us who have worked with this have watched this go many ways. It also changes with the level of cognitive impairment. When it's very mild and she's able to know, but as time goes on, or if one partner becomes more aggressive, we are still going through all of these levels of ethical principles. I also want to say that we have to use the nursing process, and we have to use all of our processes as an interdisciplinary team to look at consultating with the families and members of the health team to make these general decisions when we're talking about doing no harm. We do not stand alone in making these decisions. So let's go finally to justice. This is the one that I have always the most trouble with, the fair allocation of resources. Well, how could that possibly fit in regards to this situation? And it's interesting because in the case of these two residents, the failure to recognize their need for sexuality or their sexual needs because they happen to be older adults in a facility and manage these needs in some cases can be a violation of the ethical principle of justice. Isn't that interesting? That they have a right, when you think about this, available resources to each person. The resources in this case we might see might be privacy, having room availability for these people, setting aside time for them if this is something that has been made a decision that is appropriate for both of these people. There are many stories and amazing people in our culture, right or wrong, whether you believe or not, in how these are done. But I look at Sandra Day O'Connor. And Sandra Day O'Connor probably is one of the stories that if you haven't read about it, I encourage you to do so. There's plenty of literature about her. But because her husband found someone else in a facility that gave him great pleasure, there was no intercourse. There was no real overt sexuality other than just a sense of touch and belonging and need and being loved. And families came together and there were no issues with this, and it benefited everybody. That was using all the ethical principles that were needed here. So I think it's important to look at each of these cases. But I want to talk a little bit more about sexuality, and we've gone through now the number of folks. And thank you. Nina's just shown me we have 3 people who have joined us online, and we have 3 on the phone, 26 people who have contacted us online. So thank you for joining us. Thank you for those of you that are in the room with us today. Sexuality in regards to most healthcare professionals is something we are unprepared for. and we're uncomfortable with it, and uncomfortable addressing sexual issues that occur in our facilities and even with older adults. And I want to tell you that in all my training in nursing, in all these years, I have to tell you, I have never had this brought up in a class, in a nursing classroom, with sexuality. And only today are we beginning to see this more and more commonly. But let me say this to you, that when you read the statistics of the number of schools, whether it is social work, whether it's nursing, whether it's medical school, the profound lack of guidance for us in dealing with the geriatric population is pervasive. And so how would we be prepared to deal with this? So it's something that I think we have to be more open to, more study for. But in order to deal with sexual issues among the aging, it is imperative that we understand the physiologic changes that complicate sexuality among other older adults and allow them the full pleasure of sexuality as they age out. The statistics from AARP, any place that you want to go, show that older adults are very sexually active. How they define sexuality, whether or not it be intercourse or not, is different. And all of those provide different definitions. But in the end, it is a form of sexuality. And it is inherent in us as human beings as something that is very natural. And something we really have to work with our frontline workers to understand. This is not something to snicker about. This isn't something for them to be embarrassed about, but to accept as a beautiful part of our beings and our human nature. We must become more knowledgeable about safe sex and seniors. Now, I want you to know that most of the folks who are in facilities with us today that are 85 years and older were not discussing sex when they were younger. Their parents weren't having the discussions with them, so they're very uncomfortable bringing this up with their physicians. This is not a topic they're going to bring up on their own. Incredible literature in the book that I showed you before and in lots of research about how to bring up sexuality and talking with people. But should it be any different than talking about any other aspect of their life? We've become very open in the last few years about pain and depression, but we very seldom talk about their sexuality. And if we're not comfortable bringing it up, how will they ever bring it up at their age? Then the next thing is that we have to understand what are the interventions that we can make to promote healthy sexuality among older adults. And is that a private room? Is that a private space? And we're going to see some things also that are very interesting and uncomfortable for people to talk about. But sexual stimulation and sexual satisfaction may have been for somebody for their whole life, let's say masturbation. Well, that's very uncomfortable to watch in a group setting, nor should we have to, because if you go through the ethical principles, that does interfere with the rights of others. But that doesn't mean that we don't have the responsibility to find a place for them to be alone and to be able to have the privacy to proceed as they want. These are all issues that we're afraid to talk about. And ethically, even among ourselves, we should be talking about it and talking about it before we have to deal with it and getting used to our own opinions and our own ideas. We didn't used to talk about sex, this is for sure. But I want to tell you some other things that really have affected and why we're dealing with these ethical issues more is think about this, the Viagras and the Cialises. When we talk about erectile dysfunction, all the things that have happened medically to make this not a problem any longer for people allows people to remain sexually active far longer in their lives, maybe their entire lives. Online dating was not available to my grandmother. It was not available actually to my mother, who is no longer with me. But it has opened up a new world of communication and opportunity for people to date, and we don't talk about that. Senior communities were not common years and years ago, where today we have 55-year and older communities. I was just with my sister in Fort Myers, Florida, and I was absolutely blown away by the number of senior communities, all different types of communities that are available, that are bringing people together that may have been independent in their own homes living and not having this opportunity. The other thing that is affecting us is the higher divorce rates. So one of the articles here that and you may not be able to see it as well, but I want to just read you, but it says STDs are running rampant in a retirement community. Ethically, we as caregivers, have a responsibility, no matter what our job is to make ourselves more knowledgeable, more comfortable, and more willing to deal with these issues. And when it becomes an ethical decision making, we should be making them as informed decisions within, of course, our codes of conduct, within what we know, but also trying to remember these 4 ethical principles that we deal with when we're talking about dealing with older adults. So I hope that helps you a little bit in regards to thinking about sexuality. I'm going to talk for a few minutes about gambling, and I have a case study for this, and please contact me at mariaw@mmlearn.org. I'll give that to you again at the end if you would like that case study to be able to do it at one of your facilities or with other people, but we won't have time today to do a case study for each issue that we're going to talk about. Most of us dealing with older adults are sadly unaware of the issues and the pathological, problematic, at-risk gambling among the population that we are serving. I have to tell you, until I started doing this study myself, I think I was aware that it happened. I had no idea the pervasiveness of this problem and how much we have to deal with that maybe we're even supporting. Some of the reasons that we're seeing an increased problem with gambling in seniors is because it's sanctioned now. Many years ago, we didn't have state lotteries to be buying lotto tickets. If you look at the growth of casinos throughout the United States, it is profound. And even online betting with people who have become comfortable with computers as they're aging up and they're lonely in their apartments alone, it's surely not something I spent a lot of time thinking about. But the more I researched this in regards to ethics, the more I became concerned as senior caregivers, are we recognizing what's happening with gambling? So why should we even involve ourselves? Because if autonomy is the issue and somebody can make the decision themselves whether or not they want to spend their money on lotto tickets or at a casino, does that really involve us? Well, when you go back to the 4 ethical principles, let's talk about that for a minute. Because what we have is a group of people, and this is why gambling becomes problematic, is that it increases stress for people. We are known that there is a correlation between increased gambling and increased alcohol use, loss of income, medication noncompliance, malnutrition, and safety risks. Why do these things go hand in hand with gambling? Well, just think about this. If you're losing your money, your stress is going up. You're losing your income. You may not be even able to purchase the medication that you need to be taking for yourself. Malnutrition. So many things came out for me as I started reading this and how comfortable gambling becomes for folks. Why are we seeing more gambling? Well, the financial issues that they hope gambling will resolve. For all of us today watching the stock market alone today, think about those of us who are probably still working that are watching this today. We still have income coming in. For those people who invested and they're in the stock market, they're in bonds, this is what their retirement was invested in. Can you imagine the stress that is involved every day in the loss of their money? And so if gambling happens to be something that they have a hope, and we know how easily seniors can be influenced, think about this is, I'm going to make up for my financial loss if I win a little bit. And we've learned those first couple wins sometimes are what makes people so susceptible to gambling. Multiple losses in their lives may be soothed by the excitement or the rush of the win. What I found more interesting in the reading than this was is that when people got on buses going from independent living facilities to casinos, it is something that you need no skills to pull the arm of the slot machine. It took no special skills at all. Think about the issue of you didn't feel so lonely. You didn't feel out of place because all these other people are sitting around you doing the exact same thing. So you're fitting in where you may not have fit in any longer. People are bringing you drinks. We know that how gracious people are to you when you're in a casino. Where else in your life are you getting that much attention? And people showing such concern for you and walking around to see if there's anything else they can get you. What begins as a fun event can become an addiction. And I think this was just such a total surprise to me, and I worry about those of us who work in facilities that may be even potentiating this problem with some of the things. And I'm not talking about bingo here for a nickel. I'm talking about these trips to casinos. So what should we be doing? Well, ethically, we have a responsibility to make sure that we are recognizing. And, you know, we have the DSMs. We have, these are the diagnostic and statistical manuals for mental disorders. These are the criteria. And there is a criteria, 312.31, for pathological gambling. And I've put a link here for you to download, but there are 10 items or 10 criteria, and if somebody has 5 of those, 5 or more, they may demonstrate a persistent maladaptive gambling behavior that we should be interceding for. Because if people are losing money, they may not be autonomously making decision-making, especially if our activity directors are finding that this is high sign-up for people to go that have this maladaptive behavior. Are we in any way encouraging that? If they're not capable of stopping that for autonomy of decision-making, are they cognitively impaired and not able to do that? To do no harm, it does do harm in gambling. If somebody has spent their money and they can't take their medication, or they don't have enough money to feed themselves, or it is leading into alcohol problems. So I'm really pleased that I came across this. That this to me seems like an ethical consideration for many of us that we've not talked about. We've not spent a lot of time. So let's take a look at that. Again, if you want the case study on this, I'm delighted to send it to you. Please write to me, mariaw@mmlearn.org will work. If you have a question right now or would like to share a comment, please click on the bubble in the left-hand upper hand corner of your screen. It'll send an email to us. You can also phone in your question, 210-734-1222. All right. Oh my gosh. Driving, by far the very most sensitive issue that I have ever dealt with in ever teaching a class. And I'm going to tell you a story on myself since I have just a couple seconds and we're not getting a lot of questions. But I want to tell you that not long ago I presented a driving class. And this driving class I gave out of town in a very small community, gave just tremendous amount of advertisement for, and it was called To Drive or Not to Drive. I think I had 4 people show up for the class, and I was so disappointed. It was in the local newspaper, it was on marquees, but I had almost no one show for the class. And when I questioned people later, they said, well, I didn't want to come because I didn't want to find out I had to give up driving. It was so important and the fear was so great, people didn't even want to come to learn. So we changed the title of the class from To Drive or Not to Drive to Driving Longer, Driving Better, and had much better participation in the future. As we go through this case study and as we go through looking at the ethical considerations of driving, I want you to understand what a sensitive topic this is for everyone. To me, these are all important pictures, and we have an entire class, and I encourage you to take it online with us on Driving Longer, Driving Better, especially if you're in the health career field. But I want to talk to you for 1 second about the middle picture that you're looking at this young man with this driver's license. Have you ever seen a happier face? And if you can look back to the day that you were 16 years old and you got that license, or you had a child at 16, do you remember the euphoria of the autonomy that was involved in that day, that freedom to make that decision that you could decide whether you were going to go to McDonald's for the drive-thru or through a Dairy Queen? The same euphoria that you felt on that day, or you remember with your children, take the antithesis of that and think of what the loss is in freedom for somebody who's giving up that driver's license. So this is a very important ethical consideration that we need to talk about. And I want to talk to you through a case study and do a work through with this. Mr. Jones is 91 years old. He's a male living alone in an apartment complex. One afternoon, he had driven to the airport to drop off family members. He pulled out of the curb away from the airport, and if any of you drive to the airport, you know this is hard enough in itself for those of us. He hit a taxi cab. 3 individuals and the driver were severely injured, and one of those was critically injured. And so we have to look at what are the 4 principles that we ought to apply. If I could give you one thing to think about in regards to ethical decision making, it is not to move away from the 4 principles. For whatever you use, if you could just continue through every program to look at that, I think that would be the most important thing that you can do. Just remember these, keep them in front of you, go back and refer to them, have the definitions, get used to using them. So let's just talk for a minute about this one case. There's several different case scenarios that I have. If you don't want to use this one, we have another one that's much more serious that happens to be a true case. It was almost too much for me to handle, so I selected this case. So let's talk about the right for self-governance to decide. The right to drive is very complicated in the elderly or the older folks because it's complicated with normal changes in aging that affect our senses, our response times, and these are normal changes. Then there are pathological changes that can affect whether or not we have the autonomy, the right to make those decisions. And the reason is because of this is because in this autonomy, remember in the definition that it was choices that do not interfere with the autonomy of others in that definition. So what impact do these changes have on the driver's ability to drive have to be assessed. So we can't be talking about ethical decision making, what we should do or not do, if we haven't done a total assessment of the individual who we are talking about the ethics of whether they should drive or not drive. Now, many times this might be a case for us in an assisted living where somebody doesn't have family members, that it's up to us to be making the decision whether or not we have to intercede in regards to driving. But others of you watching this are dealing with this for family members living right at home, that this is probably one of the hardest things you will ever deal with your parents, ever, or with a wife, spouse. It's important to learn whether the physiologic changes that are affecting somebody are affecting how they are driving. And do they have disease process that we already know, such as cognitive impairment, that are totally to the point, and this is going to be a case forever throughout the United States. We will not know the answer for a long time to come, but at what point of cognitive impairment does it make you inappropriate to drive? Now, in very mild early stages of cognitive impairment, many people don't even know that they have it, and they're driving just fine. But these are the decisions in autonomy that we have to look at. So we have to weigh and assess against the client's right to autonomy the rights of others and their safety. When we look at doing good or benefiting the recipient of care, let's think about this. After you put it together, the driver's safety, and you look at a full assessment of their physical, their psychological, even emotional health to determine if it's in their best interest to continue to drive, or whether they would be safer without a driver's license, in their best interest of care, what are their alternatives? What are you going to do for this person? And I think all of those things have to be considered. In this case, maybe a driver refresher course. Maybe being with an occupational therapist, that this person could work on their reflexes, work on their timing. There are so many things, and in the driving better, driving longer, I've learned things that have helped me that I believe are making me a better driver. And Nina, I don't want to hear one word about me backing into the tree. Okay, so I did. Now, above all, to do no harm when we talk about driving. In this case, we know that harm was done to family members. And to failure on our part, again, just the same as it was with Ms. Landry, failure on our part as healthcare providers or guardians to make sure that we have done a complete and has obtained as much of a good physical and emotional, psychological assessment, that on our part would be to do harm, not to get those evaluations done. It's a nurse's duty, they say, to make sure to assess these changes and implement interventions to promote maximum safety for clients and for society, and failure to do so in this case has the potential to do harm to both. It goes against our code of ethics. and we have to follow those. And I always refer to nursing because I am a nurse, but if you're in a different career field, you know exactly how that wording goes for you, and if you don't, I'm going to remind you to go back and look at your code of ethics. Now, justice. Again, this was a hard one for me. Remember, justice is, equal share and allocation of resources for each person. I want to read this one part because this was so significant for me. The role of ageism in society often makes it easy to assume that older adults should not drive. That's ageism. We talked about when we started with ethics today, we were going to talk about age and ageism. However, while normal changes of aging impact driving ability, there are many ways in which to compensate for these changes. Consequently, full regard for the rights of autonomy must be adhered to in order for justice to prevail. In order for justice to prevail in the case of this driver and other adult drivers, should we be taking away their rights, the allocation of resources. And I want to point out to you one thing here. If we were to say, is it right to take away the license from 16-year-olds because they don't have the emotional maturity to be driving, should we equally take away the driver's license of a 70 or 80-year-old and do that based on age alone? So ageism in ethics. Should all older adult drivers be tested at a certain age? What is that age? 70, 80, 90? I have a 93-year-old neighbor who just bought a brand new Cadillac who drives to Houston about once a month. She's not had a ticket, she's not had an accident, and I bet she's a better driver than I am because she hasn't driven into a tree. Should seniors over a certain age have their driving privileges revoked to protect the public? Is this ageism? Is this ethical? These are decisions that when you apply these 4 principles will make you think differently. What is our responsibility to assist seniors to drive longer, to drive better, to drive safer? I want to refer you, some of the best information is on the AARP website in regards to this. There are lots of programs out there, but I will tell you that there's some wonderful ones by AARP. And then how do we best support families in addressing these profoundly difficult issues? Because most of the time we're not dealing with an individual alone, because not only will this impact the person who can't drive, but every member of that family who's now going to be responsible for dealing with the anger, but also with the responsibility of getting this person to their activities, their grocery shopping, their physician appointments. These are very important considerations. Finally, I want to talk about research for a few minutes in regards to ethics. And I want to know, just from a show of hands and maybe from the group that's here and in the back that are helping us, how many of you were aware of the Tuskegee experiments that were conducted between 32 and 72, 1932 and 72? I'm showing that most people here have had some, I think they're lying back here. I don't think they're telling you, they're laughing at themselves. This was an experiment. It was a large experiment, and it was conducted on just under 400 black men in their very late stages of syphilis. There were, for the most part, these were poor sharecroppers in Alabama. They were used for research, but it was interesting because they weren't used to cure syphilis, but to see rather how the ravages of this disease or what it would do to the body. It was really sad because we actually came across a drug that could cure this disease, could end the disease, maybe not the toll it had taken on the body to that point, but it didn't have to go on and result in death. And that was the occurrence of penicillin. Penicillin was not offered to these participants, and they did not understand this study. What they thought was they were going to have access to medical care that they would not have otherwise had. They were not given any risk benefit. They were not told there was a drug that could prevent the disease, or could not prevent but could treat the disease. And they had the right to be informed and to be provided with a informed consent, but they were not. I want you to know that research today is so amazing, because with our research today, every individual has the right to be informed, and we must provide them and provide informed consent that they can understand. in languages they can understand. Institutional review boards, you'll hear about these as IRBs, are charged with making sure that people who participate in research studies are aware of all the risks as well as the potential benefits. And also that no coercion is involved, which was not the case in the Tuskegee experiments. If you want to understand the importance of informed consent, I want you to go back and read some of this on the internet or get it in the book. And every medical student today that enters medical school that is involved in any kind of research, and people today in nursing research, any type of research, go back to this one case to study this in explanation of why informed consent is so important. We talk about informed consent, and we're talking about research, but I want to talk to you for a few minutes while we have a couple more minutes about all the ethical issues we have not addressed. We haven't even begun on the end-of-life issues, and I encourage you tomorrow to watch a program that we're going to have, and you can go on the internet and see, but Ask the Geriatrician tomorrow with Dr. Winokur is one you're not going to want to miss. I want to talk to you about ethical issues in regards to family rights. What about financial issues that affect the residents and their families? Healthcare issues right now are in a total flux. We don't even know how to help people with some decision making to be ethical. We don't know yet. All sorts of other addictions that happen are all ethical issues that we're faced with almost daily. And do we have the muscle to deal with it? So what guides us all? What are we supposed to do with all this? Well, like I told you from the beginning, I've always worried when we get into ethics because we tend to make it so boring, so unreal of what we're dealing with, and we're all dealing with this every day. What guides us are legal constraints. Those are the laws. Code of ethics constrain us in what we do, that we don't have a choice, that we must follow. State and federal regulations must be followed. Policies of the organizations, do they need to be changed or must they be followed? How much flexibility is in there? But these are things that guide us. These are things we need to have in front of us when we're beginning to make decisions and we're beginning to deal with ethical issues, looking at those 4 principles, then knowing what the law is, knowing our code of ethics. Do you have those books in your facilities? How long has it been, if you are a professional, since you ordered these to have? I know that it's important to me. It's something I try to do every 2 years, but I got to tell you, I'm amazed at the number of people in my own profession that don't do this. Most of all, if I can leave you with one thought, it's going to be about building ethical muscle, because you're not going to get it the day that a big decision is required. It's something that you have to start working on as a group, in a facility, or having a team around you that works together to know when right versus right is the real issue. What are we going to do? Because in the case, let's take any one of them that we talked about today in our case study, there is some right versus right here. It's not about right versus wrong. What is the best decision that benefits all? Who is your ethics committee? And what training and backgrounds do they have? Who is your ethical folks? And it doesn't mean because they're ethical people. It means because they have enough information to sit with you on an ethics committee that you trust one another, you trust their understanding. So this is imperative. The next question I want to ask you is, who will facilitate your ethical decision making? There's got to be one person who begins the process, that calls the team together, that defines what the issue is, that reviews what the codes are that you're going to be following. These are all important things in dealing with ethical muscle. I do have an answer for this one, so this is good for a second. I hope I have just a couple seconds to answer that. So, building ethical muscle does not start when you have an ethical dilemma. It must start before. If you have never sat on an ethics committee, I encourage you to ask for the opportunity to do so. It is such a tremendous learning experience. It opens your mind so much. And I think that there are many people in your community, and no matter how large your community, no matter where you're at, to try to find some folks, whether it be from a university setting, from your ecumenical centers, from different places that have sat on other ethic committees to help guide you to do this. This is not bringing the first 3 people off the floor that are very strong and opinionated. This is really making big decisions for a lot of people. It's never easy. Ethics is never easy. I have never found a true decision. Marcia, I'm so glad you're with me today. Have you ever found a really tough ethical decision to be easy? They never are. But you know what makes it easier? Is surrounding yourself with people and an interdisciplinary team that you trust follow their own code of ethics, that really know the policies, they know the law, and they have the individual's interests at their forefront of thought, not what's best for them or what they believe in. Got a great question today, and this is a question about educating retirement villages of sexually transmitted diseases. Do you have advice as to how we can approach our community of the STD issues and the methods of prevention? And I do. I want you to know that AARP has done an incredible job with that. The Essentials of Gerontological Nursing gives some wonderful approaches for that. But I think that most interesting to me has been how comfortable medical students are that have worked with this to come in and talk, and it is so wonderful. And I will tell you that my daughter is the one who taught this to me recently. But she has been traveling all over doing this herself as part of medical students that go out to do teaching. And she said it's so interesting because as other people will come through about STDs or about birth control, it's always the older women who say, I don't need that any longer. I can't get pregnant, which is the exact reason why we have so many older folks with HIV and STDs. And the younger folks are the first ones to want to explain it. And to them, it's like they're patronizing these young people, but they're learning all the time. There are amazing films that have been put out about this, and if you have any questions, and I can help you to find those resources, I don't think we should be afraid of it because it's all been done for us. We don't have to come up with this training. It has been done. It is prepared. It's in films. And when I went online to look at some different things, I saw some amazing films done on STDs in senior populations. And also, I think another very interesting thing were all the newspaper articles that I was able to pull down. And I think even putting those on a bulletin board for people to read is an essential thing to do. This is no less important than treating hypertension. This is no less important than teaching about diabetes. This is a normal fact of life. It is a disease that can be prevented where the others may not be able to be. This one we can. We don't have any other questions today, any other concerns. I want to tell you it's wonderful to be with you. We have so many programs. We really encourage you to go to mmlearn.org and see what else is available for you to watch. I look forward to our time with you for training delivered to you next month. As always, we thank you for joining us. If it was your first time today, welcome. We hope you'll join us again. Thank you so much.